trimester, we really talked about preconception counseling, which I told you guys is going to be a big component of what you do for these patients. We also talked about preconception care and talking to our patients. What are we going to talk to them about? Immunizations, optimizing their medical conditions, looking at their medications, make sure their diet is good, make sure they get appropriate referrals even before they get pregnant. Because once they're pregnant, by the time we find out, typically a lot of damage potentially could have been done to the embryo and then ultimately to the fetus. So we're going to continue on that vein today, talking about prenatal care part 2. And what happens in those subsequent visits? We talked very, very lengthy about the initial prenatal visit and all the things that happen. Now let's talk about what happens in those subsequent visits. We've got our subsequent prenatal visit. After we have that initial OB visit, we can expect for uncomplicated first and second trimester pregnancies that patients up until about 28 weeks are going to have to visit every 4 weeks with the obstetrician or with the nurse practitioner. Oftentimes they see those patients for routine evaluation. It's uncomplicated. And then from 28 to 36 weeks, about every 2 weeks, and then 36 weeks and beyond, they want to be coming every single week. Again, this is uncomplicated. We're not having any issues. Babies growing like they're supposed to. Mom doesn't have any complaints like hypertension, diabetes, uncomplicated. More complicated pregnancies, 2 to 3 times as often. I have seen patients that have to go in every single day because baby's not growing. So every day they get an ultrasound to see, do we leave baby in the belly or do we take baby out? Because if we can't feed baby in, then let's get baby out and feed baby out. So they may need twice as long. Now I have a little box down here at the bottom. You're going to see this on several slides. And really, this is just a reminder for when you're studying, say, okay, what do we do and when do we do this? What are our timelines? So about 10 weeks, we'll start to hear baby's heartbeat. We've got to start to feel movement of the baby, really between 16 and 22 weeks. And then we've got second and third trimester ultrasounds are going to be done. We've got some additional testing that will be done. And we're going to talk about this on additional slides. So that second and third trimester ultrasound. Usually that second trimester ultrasound is performed between about 18 to 22 weeks, and we consider that the anatomy scan. So they're looking to see, does baby have all the parts and pieces that they're supposed to have? What about the amniotic fluid? Is there enough in there to cushion baby, but not too much and not too little? So look at a whole host of things. And then that third trimester ultrasound is between 28 to 36 weeks. And really, that is to continue to assess baby, but really by then we're looking at amniotic fluid index to see, to make sure we have enough amniotic fluid. And what is the position of the baby? Because after 28 weeks, the baby could be coming anytime now, right? So ideally, we don't want baby coming at 28 weeks. You want up to 36 weeks, but they want to know how is baby positioned in the uterus so they can then determine if they need to put in a secondary plan of delivery for this baby. If baby is breached, then maybe baby needs to come back a little bit sooner for next evaluation to see if baby is breached. At 28 weeks, there's still a lot of movement, a lot of room for movement of the baby. At 36 weeks, there's not much room left for baby to move. So it's really important to identify what the position of baby is. Again, during that 18 to 22 weeks, we're going to do that anatomy scan. The anatomy is going to look at the head, brain, face, heart, lungs, the arms and legs. And when the radiologist does this, it takes measurements of all these different organs and organ systems. Okay? And it puts these measurements into a computer system, and then that computer system spits out if there's anything abnormal. It's not necessarily that the radiologist has memorized all this stuff, but it's a computer system that they use to help them essentially give you guys a report on what this anatomy scan looks like. It also identifies where is the placenta located. Do we have a low-lying placenta, so it's down by the cervical os, or is it up in the fundus where it's supposed to be? And at this time, we can identify what the gender is. Most of the time, sometimes we still can't at this time, but most of the time, they'll be able to identify. Now, it is important that you're going through phase 2, and you're doing your women's health or OB/GYN rotation, you've got to understand if the parents want to know what the gender is, because that is a mistake you don't want to make by saying, oh, she. Did you mean she? No, I didn't mean she. I just use that routinely, she. But then it's a girl, and you're like, oh my God. So just make sure you know what the parents want. If they don't want to know, make sure you're using like they, and make sure you're using the right terminology so you don't give away what they're thinking. The other thing that we're doing at these additional visits, we're monitoring blood pressure. That is important in pregnancy. High blood pressure is very, very bad in pregnancy because most of the time, blood pressure actually dips down a little bit in pregnancy. So that means that if someone's 140/90, that's a legit hypertension and then cause pretty significant complications in pregnancy. We want to monitor not just mom's weight, but baby's weight really, but baby's size and make sure baby's growing appropriately. And we're going to do fetal heart tones initially at that 10, the first like 8 to 12 weeks or so. We should be able to identify the baby's heart rate. And it's interesting because when we say fetal heart tones, it's actually what we're hearing is the brain waves. And the brain waves in the heart, you can't really identify specific heart tones over the heart. You're actually identifying through the brain. But either way, we call it fetal heart tones. Fundal height. Fundal height specifically is associated with how well baby is growing. And baby growth should be pretty consistent with the amount of weeks that mom is pregnant. Fetal presentation in line. Again, is baby nearing delivery, but baby is breech down or butt down? Is baby in a transverse or horizontal lie or transverse lie? We need to assess fetal movement. Fetal movement, we can typically feel about 18 to 22 weeks, and then there's a specific time period where we're going to have mom identify fetal movement every single day to make sure baby's continuing to move appropriately. And then there's a lot of other things we have to talk about how is she going to breastfeed, or is she going to breastfeed, or how's she going to feed baby, how's she going to get baby home, what about car seats and things like that. All right, so blood pressure is assessed every single visit. Again, the first part of the pregnancy every 4 weeks and then every 2 weeks. Okay. In the second trimester, we have a slight decrease in the blood pressure, and then the beginning of that third trimester is going to go back to normal. So when I say slight decrease, maybe by 5 to 10 decrease in your systolic and diastolic. Okay? The lowest blood pressure is going to be about 26 weeks, and that'll stay that way for a couple of weeks, and then go back to its baseline. So again, we have high blood pressure at 140/90. Outside of pregnancy, we're like, let's just watch it. But inside pregnancy, these patients often have to come in for further evaluation. Okay. Things that we use to assess babies. So we're going to use this Doppler. The Doppler is to help us identify the baby's heart rate. We're going to use a tape measure, and that tape measure helps us identify how large the uterus is, or uterine size. And then you can use your hands to identify fetal presentation. So fetal heart tones should be identified between about 8 to 12 weeks. Once we identify fetal heart tones, we should be able to hear them every single time, right? What that means for you guys, most of the time you're going to be in there and you're going to do the fetal heart tones, and the majority of the time you'll be able to find them. But sometimes, because remember, baby's only like 8 to 10 weeks when we can find it. So baby is really, really small. And baby has lots of room to move. So sometimes if we initially found him, we go back in, we're like, hey, I can't find him. I can't find him. They're moving the probe all the way around. Most of the time what I will say is, I talk to the patient first. If this is not their first time coming in, this is not a second visit, where did they hear the fetal heart tones last time? And that may help you. But otherwise, sometimes you just can't hear them. That's not that they're not there, but baby's so small and you're trying to go all over the place to find it. And you're getting frustrated, and the parents are getting scared, like, why can't you find my baby's heart rate? And so what I would do at Lumia, I'd be like, I'm really not that good for this. This is my rotation here, and so I'm going to go get somebody that's a lot better at this than I am, and I don't think there's any problem, but I'm going to find somebody else. Because sometimes you just can't find the fetal heart tones. Sometimes you're in there for like 5 minutes, and you're just searching for the fetal. It's okay. It's okay. If you hear something, fetal heart tone, we're looking for a rate of 110 to 160. If you hear something that's kind of midline or just off to the right or left midline, and it's like 70 to 80, that's usually mom's heart rate, and so not baby's heart rate. So then you're going to go to the side of that. Remember, baby's very small. We're searching for baby's heart rate, and so we're going to use that Doppler ultrasound to move all on the lower abdomen to identify it. Usually, kind of just above the pubic symphysis is the area that you're looking for. Fundal height. So fundal height is measured from the top of the pubic symphysis all the way to the top of the fundus. And again, this helps us identify how well baby is growing, if baby is growing appropriately. Between 20 and 36 weeks Okay, 20 and 36 weeks, your fundal height should equal your height in centimeters. So in other words, we're going to take that tape and we're going to put it on the pubic symphysis, and we're going to take the top of it, we're going to put it on the fundus. Okay, the fundus is when you feel a couple of pregnant bellies, you'll be able to feel on the top portion of the uterus, you'll feel it kind of dips down a little bit, that's the fundus. All right, so if mom is at 20 weeks, okay, the fundus should be at the top portion of the uterus, should be at the umbilicus. We take that tape and we put it up, and we're like, okay, yep, you're at 20 centimeters, and you're at the umbilicus, that's 20 weeks. Okay? So that means if she is 22 weeks, she should be at 22 centimeters. So each week we gain a centimeter. If she's at 36 weeks, okay, she should be at 36 centimeters. Okay? If you identify, okay, mom says, yep, I'm at 24 weeks, you look at the paperwork, yes, you're 24 weeks, but she's measuring at 31 weeks, that's concerning. Or she's measuring at 20 weeks, that's concerning. If we have more than a 3 centimeter difference between what is reported that mom should be as far as along in a pregnancy and what the tape measure shows us, we need an ultrasound. We've got to figure out what's going on. We shouldn't have greater than 3 centimeter discrepancy. We might have a centimeter or two. Let's say greater than 3 centimeters, there's something going on. Baby's either growing too big, okay, or there's something wrong. We have excessive amniotic fluid. Something's making that bigger, that baby, fundal height different than what we would expect. Those patients need an ultrasound. And I wouldn't say they need an emergency ultrasound today, but they're going to set them up for an ultrasound within the next couple of days. So it's not something we just want to say, well, we'll see you back in 2 to 4 weeks and we'll just redo this again. No, if it's greater than 3 centimeters, they need an evaluation to identify why the numbers are no longer matching up. Fetal movement, we call that quickening. And when this first starts, okay, depending on if this is a first pregnancy or this is a subsequent pregnancies, when it first starts between kind of 16 to 22 weeks, it feels like butterflies in your stomach. So if you're on a roller coaster and you go up and then you get that first hill down, you feel those butterflies in your stomach, that's what this feels like. And that's oftentimes what moms report that. I don't feel maybe even a little queasy, but I'm not really nauseous. They may report it as that. Butterflies are this little queasiness that they're having. That's baby moving. But again, remember, baby's still pretty small at 16 to 22 weeks. So we're not going to have baby kicking and seeing obvious fetal movement. It's just going to be a little movement of baby, and it's going to feel like that, those butterflies. We're going to see that, again, between 16 to 22 weeks, depending on if it's a first or subsequent pregnancy. Okay. And then around 28 weeks, we want to really hone in on the fetal movement. We want to make sure that baby is moving, and babies at 28 weeks, we can see them kicking, we can feel them kicking. We want to make sure that babies continue to move, because babies do sleep. They sleep in about 20 to 40 minute cycles, but for the most part, babies are moving quite a bit. So at 28 weeks, we're going to have mom do specific fetal movement testing. We want to make sure that baby is moving appropriately. Because if baby's not moving and mom doesn't see or feel baby moving, that may be the indication that baby is not doing well. That may be an indication of fetal demise, or we are trending toward fetal demise. So we're going to have mom do what they call fetal kick counts. First thing we tell mom to do is make sure you're hydrated. Make sure you're drinking plenty of fluids, okay, before you do these fetal kick counts. And then you have mom lay on her left lateral decubitus. And we often do left lateral decubitus because it takes the enlarged uterus off of the venous structure. So left lateral decubitus. And they're going to say, relax, put your hand on your belly, and just feel. Feel for the baby's movement. Feel for the baby kicking. And ideally, what we want 10 fetal movements within 2 hours. And again, most of the time, baby's moving a lot. So most of the time, within an hour, they're done. Like, yep, I feel my 10 movements, I can get up and do the rest of it, continue on with my day. But at a minimum, 10 fetal movements within 2 hours. And I would make sure you understand that. Make sure you know that. If mom says, well, I tried that, I waited for 2 hours, I didn't get my 10 kick counts, well, again, maybe baby's sleeping, So what we're going to do is we're going to say, Mom, I want you to get up, I want you to drink something sugary, some juice, some sort of sugary beverage. Because by drinking that sugary beverage, It's going to wake baby up, and then I want you to lay back on your left lateral decubus, and we're going to try this again. We're going to redo the kick counts. We're going to give that up to 2 hours, see if I have those 10 kick counts. If we don't have those 10 kick counts, they're going to tell mom, you're going to come in. Okay? If you don't have adequate movement, you can't feel the baby moving, we need you to come in. The place you're going to go to is the antenatal unit. So again, they're 28 weeks. They're going to go to this place called the antenatal unit. And the antenatal unit is the primary place for patients that are having potential pregnancy complications or those that have known a potential pregnancy. So like they have known diabetes, known hypertension, or in this case, they said, I haven't had any problem with pregnancy, but I don't feel baby moving like baby should be moving. I'm going to come into this place. So it is an actual physical location, usually in the hospital or sometimes in the clinic. It's a room that these patients go to. It also becomes this emergency department of sorts for OB patients that are beyond 20 weeks. Some places, like at BMC, we do 22 weeks, but those patients that are in the mid-second trimester. These patients that they're having any sort of abdominal discomfort, if they're having vaginal bleeding, if they had a fall or any trauma to the abdomen, they will say, go to this antenatal unit. And again, lots of patients come in there. If patients have this sudden gush of fluid, they may think, oh, I don't know, did I rupture my members? They say, go to the antenatal unit. If they have known either gestational hypertension or hypertension before pregnancy, chronic hypertension, they're going to go to the antenatal unit if they're having specific signs and symptoms. Okay, if they're having contractions or they feel like they're having contractions. Anytime they're having anything they're concerned about, they say, come to the antenatal unit, let us evaluate you, and we'll be the ones to tell you if there's something to be concerned about or not. So again, lots of different reasons besides decrease in fetal movement. You don't really, I think most of these are, probably pretty obvious. If someone is diabetic, they need to come in. If they've already been diagnosed, like you don't have enough amniotic fluid or you have too much amniotic fluid, they're going to routinely have them come in to this antenatal unit. And then twin or multi-gestation pregnancies, a lot of times they'll come in more routinely for these patients. These patients will come into the antenatal unit more routinely for assessment to make sure there's no complications associated with the pregnancy. So this antenatal unit, these patients can come in at any point after 20 to 22 weeks. But most of the time, if they're going to come in for routine evaluation, it's around 32 to 34 weeks. Okay? So prior to then, they say, okay, we're monitoring your blood pressure, everything seems to be okay, your diabetes seems to be okay, your fluid's okay, but we're going to start having you come in routinely at around 32 to 34 weeks. Oftentimes once a week, but certainly they can come in every day if needed. And what we're doing is we're trying to identify potential issues. We're trying to ultimately improve neonatal survival if we can. Okay? We're trying to reduce the risk of fetal death. We're also trying to monitor mom's chronic medical conditions a little more closely as she's getting closer and closer to delivery. Okay? And potentially, we can ultimately reduce the chance of a premature delivery if we can identify something going on early on in these patients. Okay? In the antenatal unit, there's specific testing that they will do. The two tests that they do is something called a non-stress test, which is just that. It does not place any stress on mom or any stress on baby. And then if that non-stress test is abnormal, the next test that they will do is something called a biophysical profile. So the non-stress test, that's going to be our first line to assist with fetal surveillance. And also, we put in there maternal surveillance as well, again, with those chronic medical conditions. What we're doing with this non-stress test is it's an external monitor. It's placed on mom's belly, and we're looking for fetal changes. We're looking for fetal heart rate, and we're looking for, to see if it's a certain level, and we're looking for increases and decreases of that fetal heart rate. Anytime the baby moves, we would expect the baby's heart rate to go up, and when the baby stops moving, the heart rate should go back down to baseline, or back down to normal, within normal parameter. Okay? So we're assessing that with this non-stress test, with this external monitor. Okay? And we're going to typically put these patients on a monitor for a minimum of 20 minutes. And during that 20 minutes, we're going to monitor baby's heart rate and monitor baby's movement. Again, sometimes babies are sleeping, and so they can give mom up to 40 minutes, okay, to allow for that sleep-wake cycle. But if then we don't get the response that we want, then we're going to go on to the next test, which is a biophysical profile. So again, no stress on mom, no stress on baby. What we are looking for in this non-stress test is a reactive stress test or a reassuring non-stress test. Okay? We want to see a fetal heart rate between 110 and 160, and we want to have variability in that heart rate. We call that moderate variability. We don't want baby's heart rate to be 140, 140, 140, 140. Why is baby's heart rate not increasing and decreasing? It should be, because baby's moving all the time. Okay? Mom is oftentimes having contractions, maybe not enough for her to come into the hospital, but she's having little contractions, even Braxton Hicks contractions early on in pregnancy, so the uterus can practice for the real thing. So baby should be responding to this. We don't want baby's heart rate to be consistently the same. We want this variability where it goes up above baseline a little bit and then down. And what we're specifically looking for, in addition to that heart rate between 110 and 160 and a little bit of changes, okay, we are also looking for fetal heart rate acceleration. We want to see 2 accelerations, okay, over 20 minutes. And depends on where mom is at in her pregnancy, will depend on what the number that we want to see. So if mom is less than 32 weeks pregnant, we want to see an acceleration of the baby's heart rate by at least 10 beats per minute, okay, that lasts for 10 seconds. So in other words, mom comes in, she's 31 weeks. We're doing the non-stress test, okay, and baby's heart rate is 140. We want that heart rate to bump up to at least 150. Okay, and we want that 150 to last for at least 10 seconds before it goes back down to baseline, okay, before it goes back down to 140. Okay. If mom is greater than 32 weeks, okay, we want that heart rate to increase by 15 beats and last for at least 15 seconds. So we call that 10 by 10 for less than 32 weeks, and we call that 15 by 15 for greater than 32 weeks. And this is what we're talking, this is how this is monitored. So we got that electronic monitor, and it has this paper. It kind of looks like EKG paper. But instead of EKG, we have the fetal heart rate is on top. And then sometimes we have fetal movement on the bottom, sometimes we have maternal contractions. And I'll show you the difference in just a minute. This is fetal movement because the baby is moving really quickly, in and out, and kicking in and out, so really up and straight down, up and straight down. This is your indication that it's fetal movement. We do not want this. We don't want absent variability, where we don't have really much movement at all above our baseline fetal heart rate. Okay? We also don't want this. So this bottom one here, this is maternal contractions. Contractions start, it peaks, then it goes back down where the contraction goes away. Contractions start, they peak, and they go back down. You guys can see the difference between this top one and this. This is your fetal movement straight up, straight up. You can also see that on the side here we have numbers. So this right here, this is your fetal heart rate, and this number is about 150. So if we look down through here, we can average that fetal heart rate is about in between 150 and this is 160 here. And that's okay. That's still within normal range. But if we look up here, we can see we don't really have a very good baseline. But what we do see is this. Okay? We see a lot of up and down, up and down. And that means there's something agitating that baby. That baby's heart rate is way too erratic. Something's going on, and the baby is responding to that. The way we know is because the baby's heart rate is not consistent. It goes from, on here, it looks like it goes from like 130 to 165, back down to 120. Like that is way too much. Okay? That's too much movement in baby's heart rate. And again, that's an indication something's going on with baby. What we want to see is this middle strip here. We want to see those movements. We want to see it come up and back down, up and back down, up and back down. The other thing we want to see is we talked about these accelerations. We want to see not just that it goes up and back down, up and back down. We want to see at least 2 of those 10 by 10 or 15 by 15. So if we look at this here and we say this is about 150 and it goes up to almost 160 here, and guess what? Each one of these lines is 10 seconds. We've got little lines here and then we've got these dark lines. between one dark line to another, that's 1 minute. So each light line is 10 seconds. So we said we want this less than 32 weeks, we want it to go up by 10 beats, and we want it to last for at least 10 seconds. Well, we have 10, we have 20, so this is lasting for a little bit over 20 seconds. That's an appropriate acceleration. It went up, it lasted for at least 10 seconds, and then it went back down to base. That's what we call moderate variability with acceleration. Moderate variability with acceleration. We have another acceleration here. We had a dip down here, but then it came back up to our baseline. Acceleration here, we have another one here, but just because we have those accelerations doesn't mean everything's okay. We want it has to meet the parameters. It has to be at least 10 seconds. It has to be at least 15 seconds. Not that it's just going up for a couple of seconds and then back down. It's got to meet the parameters. Otherwise, it would be considered a non-reassuring, or non-reactive, non-stress test. Again, this is just a couple more examples. So we have our contractions at the bottom. Contractions at the bottom. We'll talk about what contractions and the strength of contractions that are normal. But we also have numbers, and these numbers tell us what that contraction strength is. Okay? And typically, if we have a contraction, we're going to see some movement of baby as well. We're going to see some change in the heart rate. So we have the beginning of the contraction. If we look right straight above that, we do have an acceleration. We do see that baby's heart rate has come up a little bit. We can't really see the number underneath here, but we can see that it's come up at least one line, so that's at least 10 beats per minute. Okay, and then we know that it's lasted at least 10 seconds, about almost 15 to 17 seconds here, and it comes back down to base. So that's an acceleration. And then in between, we don't have a flat line, but we have a little bit above of the heart rate and then a little bit down. That's our moderate variability. In moderate variability, you want 6 to 25 beats per minute variability. We know we have a dark line here and a dark line here. This is our minutes. We want to look between the beginning of this strip here all the way to the end of the strip here. We want to look at that variability in the baby's heart rate. And we want to have between 6 to 25 beats per minute variability consistently. Unless baby's asleep, okay, and you'll know because we won't have much. But in general, we want to have that 6 to 25 with at least 2 acceleration lasting either 10 seconds, okay, or 15 seconds. When we look down here, we have variability. We have variability here, but that is well more than 25 beats per minute. Okay? So if we go from dark line to dark line, and we were to look at the beats per minute, I mean, shoot, we can tell right here it goes up by at least 20 beats. At least 20 beats. So you add that together, we're upwards of 40 to 50 beat per minute difference in just a minute. That's too much variability. That's considered marked variability. We want that 6 to 25. We don't want this flat line. We don't want this. We want this up here where it goes up and down just a little bit. And this reminds me more of what? Ventricular fibrillation, maybe. Yeah. All right, so non-stress test. Non-stress test. Reactive versus non-reactive. So we want a reactive or reassuring strip. We're looking for those 2 accelerations within 20 minutes. Okay, if they're less than 32 weeks, you want 10 beats per minute. That lasts for at least 10 seconds. If they're greater than 32 weeks, you want 15 beats. That lasts for at least 15 seconds. We want that fetal heart rate to be between 110 and 160. And we want that moderate variability between 6 to 25 beats per minute. And so if we are out of those parameters, those can be considered a non-reactive stress test. If we don't have the appropriate fetal heart rate changes within 40 minutes, so remember we're going to do that 20, if we don't have the changes, we can add another 20, so it gives a total of 40 minutes. If we don't have those changes in 40 minutes, there's a problem. We are concerned that there's something going on with baby. And is baby sleeping? Let's have mom drink some fluids, let's drink some sugar beverages, let's make sure baby is not sleeping. Okay? Is mom taking medications, any sort of sedatives, or is she a drug user on opioids or something like that? Okay. What about does mom have chronic asthma and she was recently sick? And is she diabetic and she's not controlling her sugar? So is she acidotic or alkalotic? All those things in mom are going to cause complications of baby. And most of the time we're going to see baby findings before we see maternal findings. So if there's something going on with baby, that might be your early indicator that there's something going on with mom as well. Again, look at this top line. We call that a sinusoidal pattern. We call that a sinusoidal pattern. This is your fetal heart rate. This kind of goes like this and like this. We don't really have this. We might think that would be a contraction, but that's actually baby's heart rate. That's really not doing much at all. It's not going much above baseline from beat to beat to beat. Okay? That is more indicative of like some sort of acidosis of baby from popping from mom. Okay? This is mom's contraction here. This is baby's heart rate. This is mom's contraction. Now we can see that mom's not even contracting well. So mom's not contracting well, baby's not responding well either. There's something going on with mom and baby. We compare this top one with this bottom one, this fetal heart rate here. You should be able to see the difference between that top one and that bottom one. That bottom one, we have that beat to beat variability. We have some variability in this top one, but it's not beat to beat. It's kind of minute to minute variability when we go up and down. We need beat to beat variability. And then you've got a little bit of acceleration here. You've got a little bit of acceleration here. This is considered a reactive non-stress test. We're seeing our acceleration. We're seeing our variability in our heart rate. This is your fetal movement. Fetal movement, we've got an increase in our heart rate. Fetal movement, we've got an increase in our heart rate, those accelerations, and then that beat to beat variability. This is what we want to see in our non-stress test. Okay, this is a non-reactive non-stress test. Non-reactive non-stress test. Again, we do not see that beat to beat variability. We don't see accelerations that meet the guidelines. We don't see the accelerations that give us that 10 by 10 or that 15 by 15. Yes, we see a little bit of acceleration here, but it's not 10 beats. It's not lasting, maybe it's lasting right at 10 seconds, but it's not meeting the parameters that we need to say that this is reassuring. This is not a non-reassuring stress test or non-reactive stress test. Okay, so if we have a non-reactive stress test, okay, the next thing they're going to do is a biophysical profile. And what that biophysical profile does, it really, again, looks at, do we have evidence of something going on with baby or even evidence of fetal demise? Okay? So we are going to take, the results of that non-stress test, and we're going to add ultrasound results to that. The ultrasound is going to look at specific parameters for the baby. Okay? Again, if mom has chronic medical conditions, they might still get this non-stress test and then the biophysical profile. So it can be done typically around 32 weeks, just like we see with the non-stress test, but as early as 24 weeks if mom is having any sort of complications. Takes about an hour or so to perform, and we're going to use that non-stress test, and we're going to add additional ultrasound parameters in there. Each one of these parts of the biophysical profile, we have 5 different variables. Each of these variables is given 2 points. So we have that non-stress test. A non-stress test, we're not having those accelerations, it's non-reactive, that gets 2 points already. Okay? With the ultrasound, they're going to look for fetal breathing. They're going to look for fetal movement. And we talk about 3 discrete, we're talking about flexion and extension. We're not talking about baby's arm is going out and it's kind of staying out there. They're not really, baby typically, when it goes out, it comes back. When it goes out, it comes back. So if we're not seeing those 3 discrete movements, that's going to give 2 more points. Okay? Fetal tone, again, we're looking for, is the baby's tone good? Not, that gives 2 points. And then they're going to also look at the amniotic fluid index. Does baby have enough, is there enough fluid in there, or is there not enough fluid in there? And maybe that's what's causing this abnormal non-stress type. And then what they're going to do is they're going to add all those together and going to see if baby's 8 or more, then that looks okay. If they're 4 to 6, not so good, and then less than 4, that's really not good at all. Okay. I wouldn't spend time memorizing all of these different parameters, and specifically what they're looking at with these. I think I have a slide though that I'll point out something that you need to know. So amniotic fluid index, this arrow's off a little bit. What they're looking for is how much fluid in there. They're looking to make sure that there's at least a 2-centimeter pocket of fluid at the deepest level. So there's different ways they can do it. They can actually do all 4 quadrants of the abdomen and they add it together, or they can just look for a deepest pocket and make sure it's at least 2 centimeters deep. So this is our biophysical profile scoring. And this is what I want you to look at. I want you to highlight this slide. So if we're 8 to 10 and the fetal pH is normal, that's overall reassuring. We did all this testing and ultimately we said, we think everything looks okay right now. And they'll give them a follow-up. Okay? If they identify, though, that there's oligohydramnios means that there's not enough amniotic fluid, okay, they're going to monitor these patients pretty darn closely. They're going to say, look, maybe you're going to come back in a couple of days, we'll see where you're at, and if we still have enough fluid in there, there is a procedure they can do. They can add more amniotic fluid, and what they do is they just add normal saline, or depending on how far along mom is pregnant, they say, we're just going to go ahead and deliver. If we have a score of 6, okay, from like 4 to 6, again, they may say come back in a day or 2, or if mom is at that 36-week mark, they say let's go ahead and schedule for delivery. Doesn't mean they have to deliver via C-section. It just means we probably need to get baby out because there's something going on, baby's not doing well. Okay, if it is less than 4, then it's not reassuring. 4 or less, not reassuring. And they're going to probably admit these patients to the hospital and do frequent monitoring. And then ultimately, if they can, they're going to deliver much sooner than later. We have a lot of other testing that we have to continue doing besides our antenatal testing stuff. We want to continue to monitor the urine. We know we do a urine at the beginning during that first visit. But they're going to continue to monitor, not necessarily for infection, but as mom's starting to feel glucose, they're starting to feel protein, especially in the setting of known diabetes or known hypertension, chronic hypertension, or diabetes that is occurring before mom was even pregnant. Well, if we did not do genetic testing, we can do it now, but usually the genetic testing that we're doing in the second trimester is because we had an abnormality with genetic testing in that first trimester. And usually it's specifically associated with aneuploidy or Down syndrome, the most common chromosomal abnormality we've seen. We've got to do antibody testing for any mom that is Rh negative. I mean, Rh negative means that they're A negative, O negative, so they're negative on their Rh factor. HIV is done as well. Syphilis, chlamydia, gonorrhea, all of those are in the first trimester. And then we're going to repeat that in the third trimester for those high-risk patients. And then group B strep needs to be done as well. Again, second trimester genetic testing is usually only done if we had first trimester genetic testing that was abnormal. So we saw that thickened nucleotranslucin, the PAPA-A, the HCG was abnormal. And, or mom has a history of chromosomal abnormality, a history of delivering to a Down syndrome patient. So what we're looking for is trisomy 21, okay, trisomy 13, and trisomy 18. And the tests that they're going to do in the second and third trimester, first test they're going to do is the triple screen. And the triple screen is done both done between 15 and 20 weeks. But if the triple screen is normal, we don't do the quad screen. Okay? The only quad screen is only done if the triple screen is abnormal. So what we're trying to ascertain with these labs, these additional labs, is what we got in the first trimester, okay, was that truly an abnormality? Do we have additional testing that supports that we are in fact continuing to be concerned with that mom has a chromosomal abnormal baby. Okay? These are still screening tests, though. They are not diagnostic tests. We're using them for screening. So if the triple screen is abnormal, then they will get a quad screen within a couple of weeks after the triple screen. Again, not diagnostic. So if in fact that triple screen or that quad screen is abnormal, okay, and the quad screen is abnormal, now we have to determine what diagnostic tool we're going to use for these patients. Okay? So if we have an ultrasound that's positive, we got a triple screen that's positive, a quad screen, we're going to get an ultrasound, we're going to do a diagnostic testing. In addition, again, patients that are 35 years and older, when they deliver, or 32 years and older, if they have multi-gestation pregnancy, those patients are often offered diagnostic testing. Okay? If they had a pregnancy previously affected by a chromosomal abnormal baby, they're going to be offered diagnostic testing outside of the screening. Okay? Or if they have a known genetic disorder. So that diagnostic testing is usually done either very early on with chorionic villus snapping. So mom comes in, she said, I have already delivered a Down syndrome baby, or I know I have the genetic disorder for Down syndrome or other chromosomal abnormalities. They can offer CVS, and I say CVS not like you go to CVS and the receipts that they give are like this long, so not that, it's chorionic villi sampling. And chorionic villi sampling, they're actually taking the chorion is the fetal portion of the placenta, and they're taking a sample of that and they're sending it off to lab. So if they have a reason, they don't necessarily have to wait for the triple screen and the quad screen. If they have a reason to be tested earlier, it can be tested at 10 to 13 weeks. But chorionic villus sampling is the earliest test that we can provide for these patients that is diagnostic, not screening. Okay? And they're going to get that piece of the placental tissue, send it off to lab. Now, because this is done early on in pregnancy, we do have a slight increase in pregnancy loss, okay, of about 0.22%, and that is just something that is discussed with the parent. Okay. Otherwise, around 15 to 20 weeks, the patients can be offered an amniocentesis. Amniocentesis, they take amniotic fluid and they send that off for testing. It's about 99% accurate. If it's abnormal, this is in fact a chromosomal abnormal baby. We do have risks that are associated with both of these. Fetal demise, about 0.2% with the amniocentesis, a little bit less because it's a little bit later in pregnancy. But also limb abnormalities can occur from the amniocentesis, rupture of membranes because you are sticking the needle through the amniotic sac, and then mom can have some bleeding. So if either one of these tests are done and mom is Rh negative, they would typically give mom RhoGAM before they do this testing. Okay. So these are both ultrasound guided testing. Amniocentesis is a needle that is going in the lower abdomen into the amniotic sac, and they're taking fluid out. And then the chorionic villi sampling is a trans-cervical approach. So they're coming through the cervix, and they have this little suction cup that comes up. They have an ultrasound, and they're going to take a little piece of that placenta and send it off to the lab. So these are our diagnostic tools, not screening tools. All right. Patients are going to be checked initially for diabetes. They're going to be at the very initial set of labs. If that is normal, they're going to be tested again later in pregnancy. And that testing occurs between 24 to 28 weeks in gestation. When you guys are in phase 2, do you guys do a lab rotation? No. So we used to do a lab rotation. I learned so much in that lab rotation. It's something to consider, if you have a couple of days, because I think you guys can do elective rotations. I would spend a week there. I mean, I had nothing for a couple of days. But one of the things you do is these patients come in the morning and you help with this diabetic screening. And so it really kind of gives you an idea of how that process goes. It also helps you, we oftentimes will have you draw blood on patients, or for those of you that have never drawn blood. Because again, if you are working with your medics and your medics can't get an IV or they can't get a blood draw, they're going to look at you as the expert. They're like, you don't want to say, like, I have never even done this. So that would be a good way to kind of get your feet wet and learn how to draw blood appropriately. Okay. But anyway, so 24 to 28 weeks, we do this gestational diabetes screening. It comes in 2 steps, and not everybody gets 2 steps, but if you have an abnormal step 1, you go to step 2. So the first step, they take this 50 grams of glucose, and they call it a glucose challenge test. It is a non-fasting lab that is done. And so they come in the morning, they drink this very amazing or not so amazing taste orange drink called Glucola, and then they get their lab test done an hour later. Okay? If when they get that lab test done, if their glucose is greater than 140, that is considered positive. Again, does not mean they have gestational diabetes, but is concerning for gestational diabetes. If it's greater than 140, then they go on to step 2. Step 2, they do 100 grams of this oral glucose. So 2 bottles of the oral glucose. And this is done after fasting overnight. So step 1 is not fasting, it's called the glucose challenge test. Step 2 is fasting, it's still called the glucose challenge test, but it's a fasting glucose. And then they're going to drink the sugary beverage, and then at hour 1, 2, and 3, they're going to draw their blood. So 3 different blood draws. And depending on what their blood levels are, their glucose levels are at hour 1, hour 2, hour 3, depending on what the results are, will then determine if they think they have gestational diabetes. Okay, so 95, you'll be fasting at the beginning. If it's greater than 180 at 1 hour, greater than 155 at 2 hours, greater than 140 at 3 hours, these patients are considered to have gestational diabetes. And we'll talk about what we do with that in a different lecture. But that's just for our screening tool. At about 28 weeks, we need to figure out how is baby presenting. Is baby head down presenting? Is baby breast down presenting? Is baby still horizontal? Is baby transverse? So we can do that via something called the Leopold's maneuver. The Leopold maneuver is where we take our hands and we determine, is this baby's head or is this baby buttock? Is it the elbow? Is it the knee? What is it? And at the beginning, the first time, a couple times you do this, you're going to have zero idea. You're going to be like, I have no idea what I'm feeling. But after the first couple of times, you're like, okay, I can definitely tell that this is the head. I can definitely tell that this is the buttocks. And so what we do is this Leopold maneuver that helps identify presentation and lie. And they're going to do that every visit after 28 weeks in preparation for if baby continues to be breached down or buttocks down, we may have to schedule a C-section. If we can't get baby turned in the appropriate position so that baby's head down, we may have to schedule a C-section. It just gives them the time frame in which to plan an additional procedure if needed. All right, let's take a break. Positive, or we don't know, about 50% chance that baby is going to be Rh positive. And Rh negatives and Rh positive, they don't like to play well together. Okay? So, but it's not really a problem in that first pregnancy because mom hasn't built up antibodies towards this protein. Okay? The real issue is in subsequent pregnancies. In subsequent pregnancies, because usually what happens at a minimum during delivery, we're going to have some blood mixing between mom, who's Rh negative, and baby, who potentially is Rh positive. If you have blood mixed between Rh negative and Rh positive, then mom is going to build up antibodies. And so in subsequent pregnancies, if mom is not treated appropriately with a medication to help prevent a reaction against an Rh positive baby, it can ultimately lead to pretty significant fetal hemolytic anemia. And so that could mean fetal death if it's not treated appropriately. So there is a medication called Rogam. Rogam's been around for a long time. And what Rogam does is it essentially binds to these antibodies. So it helps prevent that reaction from occurring. It doesn't change the blood type of mom. It doesn't change the blood type of baby. Okay, but it helps protect baby from mom's antibodies from attacking the baby's red blood cells and causing this hemolytic anemia. So when we talk about Rogam and who gets Rogam, okay, well, lots of women don't need Rogam at the very beginning unless they have complications, have anything that may have caused blood mixing early on. So we say about if they're having vaginal bleeding, they have a miscarriage, and they're greater than 12 weeks, and that would be concerned if there's been blood mixing, and those patients or those moms should get Rogam. If it's an ectopic pregnancy, the moms should get Rogam because there's always a potential that ectopic pregnancy ruptures, and we have significant blood mixing, and then that can cause detrimental effects for mom and for baby. So anything like abdominal trauma as well, that can cause fetal maternal blood mixing, those patients get Rogam. And then all pregnant women that are Rh negative, and they have, and either dad doesn't know his blood type or dad is Rh positive, at 28 weeks they should get Rogam. Now, I say that if we don't know what dad's blood type or dad is Rh positive, but There are a lot of places that it doesn't matter. They're just going to give mom RhoGAM. They're not even going to test dad. I was recently talking to a student whose wife was pregnant, and he said, I'm Rh negative, my wife is Rh negative, like the baby is not going to be Rh positive, right? But they still insisted, Nancy still insisted that they get RhoGAM. There is a significant shortage of RhoGAM. So there's a lot of places that say, we're not doing that anymore because we don't have the RhoGAM to do it. We're only doing that if mom is Rh negative and dad is Rh positive or unknown father. But 28 weeks of gestation is the time to initially get it. And then within 72 hours of delivery, if baby is identified to be Rh positive, then they will give mom RhoGAM again. Okay, so RhoGAM again at within 72 hours of delivery. And we used to have this micro dose of RhoGAM. I think the only version they make now is just 300 micrograms. We used to say, well, for less than 12 weeks, and maybe we can give it a little bit, we don't have to give a lot, but now everybody just gets the same IM standard dose, which is 300 micrograms. Which means it's really important when patients come in, we're seeing these patients that have vaginal bleeding, we know what their blood type is. And can we trust what they say? We want to. We want to be able to trust what they say, but we can't. Legally, we can't. We must have a blood test that shows they're Rh positive or Rh negative. So you've got to order a blood test for them, and usually that is done by the blood bank. If you're doing that in an outpatient clinic, you're not going to get that test back for a couple of days. And that's okay. I've seen lots of patients go home and then they have to come back. Usually, ideally within 72 hours, we like to give them this RhoGAM. Okay. And it lasts for 13 weeks. So again, if mom comes in early on in pregnancy, she has to get RhoGAM for something, and then 15 weeks later she comes back, she has abdominal trauma, she may need RhoGAM again because now she's beyond that 13 weeks. All right, let's do a check on learning. Antenatal testing, 33-week gestation. What is reassuring? Non-stress test. Which one of these is reassuring? Charlie, right? 15 by 15. We want to have those two accelerations, the fetal heart rate within 20 minutes over 15 by 15. That is correct. All right. HIV screening. HIV screening is done in all new OB unless they opt out, or it depends on state law. So some state law requires everybody to get, and some people do not require it, or some states do not require it. Okay? If it is negative, it can be repeated in that third trimester for those high-risk patients. High-risk patients with multiple sexual partners, history of multiple STIs, and things like that. If someone is positive for HIV, they have known HIV, okay, then they're going to, and if they're not already on medications, okay, then they're going to continue to monitor them throughout. So if they have to put on medication, within 2 to 4 weeks, they're going to check their HIV again. Check their viral load is really what they're checking for. Not really if they're positive, negative, already know. So check their viral load, which is usually done by like a CD4 count. And then they're going to continue to monitor that viral load at a minimum of every month, okay, for the next 3 months. And then as mom gets closer and closer to delivery, around that 34 weeks, they're going to check the viral load again. And that does is that helps us determine how mom should deliver this baby. Mom may want to deliver vaginally, but she may not be able to deliver vaginally because of her viral load, or she has a higher viral load. The other thing that we want to keep in mind with patients that do have HIV, that increases the risk of other infections. HIV, even if their viral load is low, is still a chronic inflammatory state that these mothers are in. Okay? So it increases the risk of urinary tract infections. We want to monitor and talk to our patients about signs and symptoms of that. Other sexually transmitted infections as well, and then postpartum infections. We have increased risk of mortality if patients are not on antiretrovirals. So we do recommend all HIV positive mothers be on antiretroviral therapy. We do have up to a 30% vertical transmission, so from mom to baby, that can occur either during pregnancy, during the delivery, or even post-delivery as well. So how do we manage these patients that are HIV positive? We want to make sure they stay on their antiretrovirals. If we can have them stay on their antiretrovirals throughout the pregnancy, it doesn't make the vertical transmission 0, but it reduces it from that 20 to 30 down to about 1 to 2%. If they have a viral load and it's less than 1,000, if their viral load is less than 1,000, they can opt to deliver vaginally. If the viral load is greater than 1,000, then the recommendation is C-section delivery to help reduce the risk of vertical transmission during delivery. And we used to think about HIV as a contraindication to breastfeeding. It's become more of a relative contraindication. If mom is otherwise healthy, their viral load is low, they're on their antiretrovirals, then they can in fact breastfeed. If they have cracked nipples or bleeding nipples, we do want to caution them because that can be a source of transmission of the HIV virus to the baby, and so they may choose not to breastfeed if that is the case. Okay? But we do have still about a 10 to 20% risk of transmission to the baby via breastfeeding, but much lower as long as their viral load is low and they're taking their antiretrovirals. Gonorrhea, chlamydia is screened during that initial screening, during the initial OB visit, and then again in that third trimester for high risk, the same thing we talked about with syphilis as well. And that is important because moms that have gonorrhea or chlamydia at the time of delivery, we have significant increase in chance that baby's going to have some signs or symptoms of that as well. Neonatal conjunctivitis, which can cause scarring, which can lead to blindness. Chlamydia pneumonia, these babies can get very sick from chlamydia pneumonia, they become septic, and also same with gonorrhea, they can have conjunctivitis. So when you're seeing these babies, if you are in fact in a position where you're doing the well baby checks, and baby comes in at 2 weeks, they have a bunch of discharge coming from their eyes, you don't want to just assume that it's some sort of just viral or bacterial conjunctivitis. Early on, that young, we want to make the assumption really that it might be gonorrhea or chlamydia conjunctivitis, and that needs to be treated as such. Okay? Remember that we often have a co-infection rate between gonorrhea and chlamydia, so we want to make sure if mom has one, we treat them for both. Group B, hemolytic strep, that is a bacteria that is found in the vaginal area and the rectal area. And outside of pregnancy, we don't really think that big of a deal, but in association with pregnancy, it's a big deal. Actually, group B strep is the #1 cause of neonatal sepsis in the United States. In addition to sepsis, we have a lot of other complications. We have respiratory distress syndrome. These babies can have pre-bed pneumonia, meningitis, and ultimately can lead to fetal death. About 1 in 4 women are carriers, okay? And about 1 to 200 babies have some degree or are exposed to group B strep and have some degree of group B strep disease that is identified shortly after delivery. Okay, so what that means for us then is we screen all pregnant women between 36 and 37 weeks, screen all of them for group B strep. Okay? That being said, they may have been screened previously. So if they had a urine, and in that urine was group B strep positive, that is our screening tool. So if they have not had a positive urinalysis, then we're going to screen them. If they had a history of I delivered a baby and that baby had invasive group B strep, meaning they had group B strep meningitis, they had sepsis, they had acute respiratory, so if the baby was really sick from group B strep, we can test them. We can test them still at 36 to 37 weeks, but we're automatically going to assume they're a carrier and we're just going to treat them. Okay? So even if that test is positive, they've proven that they're carriers. We're just going to go ahead and treat them. So there are patients that need intrapartum antibiotics. Intrapartum is I am delivering, I need antibiotics during delivery. Okay, so not a couple weeks before, but actually during delivery, they'll give them penicillin. Okay. So again, if they have group B strep bacteria in this pregnancy, if they have a previous infant that they were delivered and had invasive group B strep, then they need intrapartum antibiotics. They're going to get that penicillin while they're in labor. If they have a positive group B strep culture, so that culture is a swab of in the vagina and the rectum at that 36 to 37 weeks. The other reasons to give antibiotics, if they're unknown group B strep, and the baby is being born and mom is preterm labor, so less than 37 weeks, we don't know what the results are. We're just going to give antibiotics because if we'd rather give the dose of antibiotics than baby be born with group B strep. Okay, if they have an amniotic rupture greater than 18 hours, not 12 hours, not 6 hours, not 10 hours, 18 hours, I already know that, then that is concerning. That is concerning that mom has a potential ascending infection, and that can cause pretty significant issues with the baby as well. If they have a fever intrapartum, they start running a fever, they're going to give them antibiotics. Okay, of course, like I said, if they're positive, or if they have that positive group B strep in prior pregnancy. Indications or times that we do not think that intrapartum antibiotic is indicated. Okay, if they have a negative culture, there's no reason to give them intrapartum antibiotics. If we've determined that they're going to do a C-section delivery, okay, that has already been determined, remember that this is a bacteria that's held in the vagina and the rectum. Okay, so if they're doing C-section delivery, baby's not coming through that area, we don't need to give intrapartum antibiotics. Again, they have negative swab, or urine is negative. So the biggest thing, really, not that much. So if they have a negative swab or the C-section, then we can say they don't need intrapartum antibiotics. Other things that we have to talk to our patients about. Are they doing childbirth classes? If not, we certainly can encourage them and give them the opportunity. Someone's sleeping? We can talk to them and give them pamphlets for childbirthing education classes. They can do a Lamaze technique. They can hire a doula. Doula is a specially trained person that helps them through labor and delivery. Who's going to take care of baby once baby is born? Again, the military are kind of protected, but for you National Guard and Reserve folks, that may not be the case. They may not have someone, they may not have a pediatrician. So the obstetrician is going to take care of mom, but who's taking care of baby? If this is their first pregnancy, they may not know what it feels like to have a baby, or they don't know what it feels like to have a baby, right? So they may not know what the signs of labor are. When should I come in? Like how long should I have contractions before I come in? So we're talking about that. Again, how are they going to feed baby? What kind of pain management do they want during the delivery process? Do they want IV medicine? Are they going to want to have epidural? What are they going to want? Postpartum depression, we talked about that already. What do they do, and how do we screen for that postpartum? And then postpartum contraception as well. So, labor and delivery. We want to make sure that we understand what mom's idea and what is her plan for the laboring process. Okay? That includes anesthesia. That includes, if she's not going to use anesthesia, we talk about breathing techniques or breathing techniques in association with anesthesia. What happens if there's complications? Mom wants to do a vaginal delivery, but there's complications associated with the vaginal delivery. What is our next step? And we're going to talk to the patients about that. What, again, is the birth plan? Is mom going to deliver vaginally, or is mom going to deliver via C-section? What are some emergency indications for mom to present to the antenatal unit? If she's having vaginal bleeding, if she's having regular contractions, right, 3 to 5 minutes apart, if she has evidence of rupture of membrane, then those talk to patients about going to the antenatal unit or to the emergency department. Breastfeeding. Breastfeeding is great, and we do encourage moms to breastfeed. Okay? We have lower rates of infection for babies. We have lower rates of sudden infant death syndrome. Okay, and we also have lower risk of breast cancer in mom, ovarian cancer in mom, diabetes, hypertension. All of that is associated with breastfeeding. Okay, we do have some contraindications. You can take HIV off there. That is not a contraindication anymore. But if mom is addicted to drugs, okay, those drugs are then going to be related to baby, and baby can have problems with respiratory depression, somnolence, and not do well because of chemical dependence. Okay? Also, if mom has active TB or is on medications for TB, we typically do not recommend breastfeeding. Isn't that cute? Where should I go, Grandma? Reminds me of that movie. What was that? Austin Powers movie? He's such a weird dude. But it was a good movie, but he's so weird. And then, so we talk about uncomplicated pregnancy. As long as we have no issues with pregnancy, they may allow mom to carry beyond term. They may allow mom to carry beyond that 42 weeks. But once we come to that 42 to 43 weeks, we're going to need to start figuring out how we're getting this baby out. So first of all, the placenta doesn't have a ton of nutrition left in it around that 42 weeks. Okay? So we got to get baby out so we can provide nutrition for baby. These babies can have this intrauterine growth restriction that develops because we don't have the placenta providing those nutrients. So we got to figure out if we can allow baby to stay in there because it's uncomplicated, but eventually baby has to come out. We'll talk to mom about the postpartum delivery process. If mom has had a prior C-section, they may, in fact, ask mom to have another C-section. There is something called child labor after C-section now. So if mom's had one C-section before, oftentimes they'll allow mom to try a vaginal delivery. If they've had multiple C-sections or other uterine surgery, then again, they usually will encourage them to do another C-section because it increases the risk if they carry baby to term, increases the risk of placental abruption. So oftentimes what they'll say is you can deliver vaginally if you want, but we're not gonna allow you to carry to 40, 41, 42 weeks. We're gonna have to deliver a little bit earlier because we don't want the uterus to be fully distended and have that increase of uterine rupture. Okay. We gotta talk about when mom and baby are gonna go home. How are they gonna go home? Does baby have a car seat or not? My son is 16. I adopted my son when he was 4 days old. They brought him to my house. And it was kind of an interesting story. I was on shift at Banshee in the ER. And I've been going through the adoption process for a couple of months. And I get a call that day on the shift and like, hey, we're going to come and visit you for your routine visit this afternoon. Oh yeah, I'll be off shift and I'll be there. So we'll be there about 5 o'clock. Okay, yeah, perfect. Well, then they called me back. I was like, oh, that's kind of weird. And they said, hey, we have this baby. And they talked to me about the baby, and do you want to be put on this list for the baby? I'm like, yeah, I guess, put me on the list for the baby. Baby's 4 years old. Okay, so then about 2 hours later, they call me back. Hey, you're still on the list. I'm like, yeah, I'm still on the list for the baby. I don't even know what that means, but okay. And so next thing you know, like I called my caseworker, and I'm like, hey, I'm running a little bit late. I'm just now leaving the emergency department, but I'll be home in like 20 minutes. He's like, okay, great. I'll meet you there. And oh, by the way, the other caseworker's on her way with the baby. I guess I got the baby. I mean, it's like the weirdest thing, right? So sure enough, he shows up, and then the other lady shows up, and she's got the little baby and a little tiny thing, puts him in a car seat, or a little, I guess it's a car seat. I was in a car seat. I don't even know what it was, just a little, I think it was a car seat. But it was kind of just like, here you go. And then she took the car seat. And I was like, oh my God. So in between her coming and him and I meeting, he said, okay, well, she's on the way. Like, where's the crib? And do you have a car? I'm like, well, you just called me. And I was on the list. I didn't even know. He said, well, she's going to be here in like 30 minutes. Can you go and get things? And I'm like, okay, I'll go get things. So Walmart's just up the street. I go into Walmart, I'm running, I'm sweating, I'm like, oh my God. And there's a lady over there in the baby department. And I said, do you have, like, I need things. And she's like, well, what are you talking about? I tell her the story. She's like, oh my God. So she calls on the radio. Hey, we need some help over here. And next thing you know, like 5 people show up and they throw all this stuff in my car. Off to the car we go. And I don't have a crib or nothing. So we load up the crib. And we get back to the house just in time, and she shows up and she drops the baby. Okay. So she gives me like 20 bottles of this formula. Like, that'll last like a month. Like, that's plenty of food for this baby. And so she says, sign here, sign here, sign here, and she's gone. Like, within 10 minutes, she has left the house, and I got this baby, and I'm just like,
Christmas do.
And I'm like tiptoeing around the house, like, please don't wake up. Like, it is so bad. They do not prepare you for this in any of your classes. Like, please don't wake up. Well, he wakes up, and I'm like, oh my God. So I put 1 bottle in, 2 bottles in, 3. I'm like, wait a minute, like, we gotta ration this. You know, like, I'm 20 bottles. Like, what is going on here? And so, this car seat though, I have no idea how to put this car seat in the darn car. Like, I put it in there and I'm like, well, this doesn't seem right. So I take it out and I move it around. Like, I mean, I knew it had to be rear facing. I could not get that seat belt to figure out how to get that around. So I called one of my friends and she's like, well, go to the fire department. They'll do it for you. I'm like, I am not going to the fire department. Like, you come over here and help me right now and get this big car seat in this car. And so she comes over, she helps me. So we're like now about 3 weeks into this. I figure out the feeding, and he doesn't sleep at all night long. He sleeps during the day only and is awake all night long. About 2 days into this though, it's right around, he's born on the 18th of December, so now it's the 22nd, and like, I'm gonna drink some wine. I'm like, I need some wine because he is not sleeping. So I drink wine, which I had like 2 glasses of wine, and it was terrible idea because he's awake all night long, and I'm like, I'm not drinking ever again because he's not sleeping and I can't drink. So I really did not drink for almost a year because he just never slept ever. And so finally though, we're about a month into this, I suddenly put the crib. Like, I'm just trying to get through day to day to day. I still have to go to work, because I was at BAMC and the ER, so I gotta go to work. So I bring him to work with me, and we sit in there all day. They said, you don't have to do shifts, so you can bring him. We don't have no daycare set up. He's only like a week. It was terrible, absolutely terrible. And so finally, we get it worked out. Finally, about 3 months in, he started sleeping. We got the car seat, the crib is up, and we all survived, and now he's 16. And it's back to being very terrible. Oh my God.
Now it's terrible.
So the crib, so you gotta make sure you know how are they gonna sleep? So when they're back to sleep, we don't put babies on the front, but moms don't know that if they haven't had a kid before. And then when is baby gonna get circumcised? When is baby gonna get circumcised? They need to have their vaccination. And then vitamin K. So you usually do 1 injection of vitamin K, and that helps prevent bleeding in the baby. They will usually discharge them home with conjunctival eye care. They'll give them some erythromycin for them to use for the first 5 days. And then, so that's why if you see them a couple weeks later, they have discharge, and that is very concerning. All right, immunizations for mom. We already talked a lot about immunizations. Mom can't have live vaccines, so we want to make sure that mom is immunized prior to pregnancy, except for Tdap, 27 to 36 weeks. Mom should get her Tdap. And then hepatitis A or B if high risk during pregnancy. Here's a couple of slides with some areas in red, some areas in yellow, some areas in green, just kind of some immunizations that we want to talk to our patients about. And these are your minimum precautions. These are the things that you're going to talk to these patients about in the first visit, and then all of those subsequent visits, and when they should come back, and then their routine follow-up. Right?